So this is a presentation, CME presentation on neurobiology of substance abuse and substance diversion. So this is something um, very, very important for all of us. And I'll go through some of the neurobiological aspects of substance addiction without going too granular about basic sciences. And for most of you, it'll be just a revision. Those who are taking board examinations, including myself, it's a good revision of things because a lot of these things are asked in, at least in psychiatry board examination, and sometimes in primary care and internal medicine also. As you can, I just mentioned, please text your first name and last name that if you need credit for with this message to this number. Okay, so we're talking about addiction here. So addiction can be described as a repeating cycle with 3 stages. Look at this as 3 stages, and I'll go in more details about it as what these 3 stages are. And the reason we are bringing up these 3 stages because we have been able to locate each of the 3 stages of addiction with one particular area of the brain predominantly. And that's something very, very important to it. And what are these 3 basic brain regions that are involved in addiction process? They include the basal ganglia, the extended amygdala, and the prefrontal cortex. So again, these are basal ganglia, extended amygdala, and the prefrontal cortex. So, just a revision for us. What is basal ganglia, extended amygdala, and prefrontal cortex? How are they related to our concern in topic and concern? So the basal ganglia controlling the rewarding or pleasurable effects of the substance use, and mostly are involved in the formation of habitual substance taking. Now, what is habit? So habit is not something that we in addiction medicine, we don't take it as a regular lay term for habit. Habit means something that is cued, a behavior that is cued by external environment, right? And that has, when done over and over again, leaves a fine imprint on the brain circuitry. So that's a habit. Typically, they say, suppose we are trying to start a new habit, any new habit, say, for example, exercising every day, it usually takes about 120 days or to 3 to 4 months to get that habit ingrained, right? So this is the habit of the substance abuse. The second portion is what we call the extended amygdala. Now, what is the role of the amygdala? It is involved in stress, right? The feeling of uneasiness, anxiety, irritability, right? That is typically extended, this accompanied through substance withdrawal, right? Amygdala in psychiatry particularly has a very extensive role, particularly anxiety and PTSD and other forms of emotional problems. And a hyperactive amygdala is a cause of a lot of discomfort, and patients who have a hyperactive amygdala, for whatever reason, be exposure, trauma, substance, anything, are very restless, irritable, and they tend to do things or strive to engage in behaviors that are derived to calm down the amygdala, right? So keep that in mind. So we have basal ganglia, rewarding and pleasurable things, and also the extended amygdala involved in substance withdrawal feelings, mostly underlined by uneasiness, anxiety, and irritability. And evolutionary, we have a much higher cortical area, which we call as the prefrontal cortex. Now, this is a very higher evolutionary scale. That means more recent evolutionary addition that we have had, that is designed for a lot of executive functioning. That is ability to organize thoughts, activities, prioritize thoughts, manage time, make decisions. So a lot of those things that which as human beings we have, is probably because of prefrontal cortex, and it has a lot of control, including substance intake. So we have three basic three components in substance abuse concerns. Let's go into more details about what each of these three areas are there. Now, basal ganglia keeping mostly involved in movements and coordination, right? As you can see, anytime that we have in Huntington's or any kind of movement problems, sudden hand scoria, whatever we have, it usually involves basal ganglia. Even Parkinson's disease may involve some, to some extent, basal ganglia, right? But routine, and it's also involved in routine, learning routine behaviors and forming habits. So this is something, what we call muscle memory, right? The muscle memory that the moment we engage into some form of, we get some environmental cues, we go into some form of movements. A very typical example would be, for example, many of us, when they wake up, the first thing they go is go to the bathroom and brush teeth, for example, then look for coffee or some kind of drink. And this may be varied for everybody, but if you think about it, they are they're consistently same over a longer period of time, right? And so routine learning involves two sub areas. The one is the nucleus accumbens, which is involved in motivation, reward experience. And then we have a dorsum stratum. The dorsum stratum is also involved in, so the nucleus accumbens is involved in motivation and experience of reward. And the dorsum stratum is involved in forming habits and other routine behaviors, right? So just put this in mind, and it'll come all together when we talk about substance addiction and the behavior effect of why these folks struggle with repeated relapse and continued use of substances. Moving on, the extended amygdala. It is located just beneath, this is kind of green, nodular, green rounded body over here. And this is mostly involved in fight or flight kind of response. Negative emotions, usually when triggered, uneasiness, anxiety, irritability. But the problem is amygdala has got a close buddy called hypothalamus, right, which it interacts very closely. This is thalamus, and underneath that is hypothalamus, which is involved in stress and regulation of other bodily processes. So as you can see now, substance addictions controlled by basal ganglia and amygdala so far can not only make the user feel have a jittery stress regulation problems, but also it can also interact with hypothalamus, which controls a host lot of other bodily functions. Now the prefrontal cortex, the executive functioning, as we just talked about it. Again, executive functioning involves in very high functioning activities, mostly organization of thoughts, prioritizing tasks, management of time, making decisions, and of course, regulating emotions and impulses, right? So those are that's the prefrontal cortex. Now, bringing it all together, if you go through the cycle, and I will enlarge this more and talk more about it, if you do the three-stage cycle framework of substance abuse that is neurobiologically ingrained, and if you can see that the first one is a binge intoxication, which is more of a behavior that it coincides with the basal ganglia part. And then the extended amygdala, you're mostly involved in withdrawal symptoms and negative emotions, right? And then finally, the preoccupation, the anticipation of substances or getting cued by any drug paraphernalia or any kind of thing. What cues them is, and the preoccupation and anticipation of having seeking one substance is actually done through the prefrontal cortex. So you have three stages: binge intoxication, in which the individuals consume the intoxicating substances and experiencing its withdrawing or pleasurable effects, depending on where they are. And the negative affect are usually involved with the withdrawal, with the extended amygdala, and then the preoccupation part. Right. Other things that may be involved, there's 4 specific kinds of behaviors that are central to addiction cycle. And this is something we have been able to break down why addiction goes in a circular way over and over again. So the first thing we say is impulsivity. And of course, in between the two is positive and negative reinforcement, and then the compulsivity. So impulsivity is inability to doing something impulsively means doing a task without thinking, right? So you're accomplishing a task without giving a whole lot of thought process into it, usually driven by urges or those kinds of impulses. Compulsivity is not able to stop an ongoing process, and that leads to repetitive behavior. And this is very important to understand the two difference, because later on we can look at the neurobiology and see that which areas are predominantly affected when the patient has impulsivity versus compulsivity. In other words, impulsivity is the inability to resist urges in terms of substance abuse, delay gratification, not able to stop or delay any form of gratification, right? And unreflected decision making without giving any thought process, without any foresight, without thinking what the consequence of the action would be. Yeah, whether that aligns with the long-term goals or not. That's one thing. Compulsivity, right, is repetitive behavior that is inappropriate for a particular situation, right? And they know that this is more on the OCD spectrum. This can be a part of OCD spectrum because then the pathways remain the same, that even though they know it is harmful, but they nevertheless feel emotionally compelled to perform them. And so why do they do that? They do that to neutralize stress, tension, and anxiety. So impulsivity and compulsivity are very strong features that are ingrained in the neurobiology of addiction cycle. And then the positive reinforcement, once you engage into such kind of behaviors, right, they get some reward in it. And it could be any tangential reward, right? And anytime they get a release of stress or feeling relaxed or feeling high, whatever it is, that kind of sensation gives a positive reinforcement, which in turn increases the probability of a response like drug taking behavior, right? And then negative reinforcement is a term used, the process by removal of a stimuli such as negative feelings or emotion, again increases this drug taking behavior. So positive reinforcement, something they get positive that reinforces the behavior. And the negative reinforcement is removing an irritant, also like removal of stress, can also lead to a higher probability of taking drug or taking drug-taking behavior. So impulsivity, positive reinforcement, negative reinforcement, and definitely compulsivity. These are the 4 behaviors that are central to the addiction cycle. Now, the reward circuitry, as we can call it, what is this reward circuitry? Where does it really hone down to? And what neurochemicals are actually involved in it? So this is a very good schematic diagram where I can I can show you here that the reward circuitry comprises of the ventral tegmental area, VTA for short, and the nucleus accumbens, VNAC for short. And if you can look into that, number of substances can be directly linked to a particular neurochemical. For example, let's take the one on the top. Yes, alcohol, for example. So drinking alcohol hits the opiate peptides, which in turn leads to stimulation of release of opiates or opioids into the nucleus accumbens. So this will be a positive reinforcement behavior. Alcohol, opiates, leading to, and the ventral tegmental area will also lead to opiates into the nucleus accumbens, right? Taking the other ones, chemicals that hit the GABA, right, which is the ventral interneuron area, where you can see cannabinoids, even alcohol or opiates. So alcohol has got 2 areas. One is the GABAergic system and the opiate system. And that explains why medications like naltrexone, for example, are so effective in reducing craving. And it will not cause any kind of problem with the reaction like the antabuse does, but it just reduces the craving. How does it reduce the craving? By taking naltrexone, it neutralizes the opiate system. So you can drink alcohol, but alcohol will not give you any kind of kick that usually people get when they drink, an opiate system kicks in. So if you neutralize the opiate system, alcohol tastes just like water. And so the positive reinforcement that patients get on drinking alcohol, that dies down. Similarly, over here, if you see the dopaminergic system, nicotine, as you can see, it's on the nucleus axon area, and then on the dendrite terminal, again in the ventral tegmental area, causing and then communicating through the dopamine to nucleus accumbens. Again, same thing. So these two major areas, ventral tegmental areas, nucleus accumbens, remain the major binge intoxication stage and involving basal ganglia, that involves basal ganglia. Right? And as you can see, the alcohol substance progress, repeated activation, if this circuitry does over and over again, what we call long-term potentiation, right? The habit circuitry will become strengthened and strengthened. Right? And so just like any habit, the more we do that, the more the muscle memory develops and the more strength it becomes, right? So this has become what we call the development of habit. Right. Going on to the same principle, the same reward and habit neurocircuitries, it also explains what we call the craving and the compulsive substance use, right? So binge intoxication stage or addiction cycle is that stage at which individual consumes the substances of choice, and everybody has got a different choice, right? Patients who are addicted, they will tell you if what the substance of choice is, right? One, they may say that alcohol will be my substance, or even the stimulants, they may differentiate between meth and say cocaine, for example, right? And so their brain circuitry is so adapted that one of the substances gives them the maximum kick, maximum response, right? Compared to the other substances. So not everybody who uses cocaine gets to become cocaine addicted. Not everybody who is using, say, for example, alcohol becomes an alcoholic. But why this? So it depends on the environmental factors, genetics. Of course, there are other factors involved there. But the brain neurocircuitry involving mostly nucleus accumbens and dorsal striatum, along with the basal ganglia, the main part is plays a very crucial role in this one. Now, the negative effect, if you look at the negative effect of the withdrawal symptoms, now we are going towards the other part of the brain circuitry. This involves a number of different neurochemicals. The withdrawal negative effects involves a couple of other neurotransmitters, including the corticotrophin release factor and dynorphin. And it's part of the amygdala, extended amygdala. Right? And so withdrawal it involves what? Decreasing the function of the brain reward system. So if the reward system is negatively affected, it will cause some withdrawal symptoms, right? And so what the patients do, they drive to elevate these negative feelings. You know, the old dictum that says is, I started drinking first, now the alcohol drinks me. You know, all alcoholics will tell you that. Initially, I used to enjoy drinking alcohol, but I don't have a choice now because the alcohol drinks me. That's a pretty famous line in the Alcoholic Anonymous circuit. And this is exactly what it captures. It captures the fact that alcoholics, after a long period of time, they are mostly trying to avoid the negative reinforcers involving mostly the amygdala, extended amygdala, right? And that drives what we call the compulsive substance taking. Remember, the compulsive part of this addiction includes the patient knows it's bad for them. They know there's no utility on that, but this cannot stop a behavior. right? So initially it starts with impulsive drinking. Now it's more towards compulsive drinking because they are trying to neutralize any negative feelings that may arrive because of because of discontinuation of substances. And finally, we are talking about the executive function deficits. Now, what is the execution deficits? Now, this involves disruption of the executive function, compromised cortical function, prefrontal cortex. In this case, glutamate is increased, right? So, and it drives the substance use habits associated with craving, and also influences dopamine in the frontal cortex. Now, in our board examination, in a psychiatry board examination, this is a board question for us. The role of glutamate and dopamine. I'm sure other specialties ask this topic also, the role of dopamine and the role of glutamate in terms of craving, and where does it affect and how does it function. So as you can see that substances that are used for craving, one of the substances we use besides naltrexone involves directly with glutamate, right? And then we have the other activation. And so what we see over here is so substance addiction we can visualize as a go system and a stop system, right? So when we have an overactivation of the go system, right, that promotes what we call habit-like substance seeking, compared to the stop system, which is much subdued when active substance abuse, leads to underactivation of stop system, leads to impulsive and compulsive substance seeking. So it's just like a car, right? If you're putting too much of gas and without having adequate brake, the car goes berserk. Same thing over here. We have overactivation of the go system and underactivation of the stop system, which is mostly involved through glutamate in the prefrontal cortex. And this is a summative slide to show the interaction of all the three elements, the prefrontal cortex, the basal ganglia, and the extended amygdala, the use of all the neurochemicals here, and the basic brain areas that are involved. Now, I do want to bring some of the more concept about the impulsivity and reward system. This slide is from a textbook, as you can see, it's from Stahl's textbook, which I just added today because I was reviewing the slides and saw that this would be a very good addition to see that. And so go into a little bit more details about why these patients have such high degree of impulsivity and why they have such high degree of compulsivity in motor response. So when you see that in this circuit, this circuit, as we go into a little bit more details on that one, so you see what we first call the ventral stratus. This is the stratum, right? And which projects into ventral stratum, projects into the thalamus, and that goes into the ventromedial prefrontal cortex, and the ventromedial prefrontal cortex goes back to the stratum, completing the circuit. Any disruption of this circuit is known to cause impulsivity and reward problems, right? Now, what area of the brain modulates this circuitry from going haywire? It is our top-down mechanism, which is the prefrontal cortex, which is the ventromedial prefrontal cortex. Now, I'm not sure about internal medicine or family practice, but this is a very important academic and neurobiological understanding of addiction for psychiatry, for addiction psychiatry. This is a very important modulation. So people with deficient ventromedial prefrontal cortex can tend to have a high impulsivity. And similar thing in compulsivity, here it goes into ventromedial, orbitofrontal cortex, but same dorsal stratum along with the thalamus, but involves the orbitofrontal cortex in compulsivity. So this is more of an academic understanding. The next slide I would bring to your attention. This is a good slide to show that substance addiction is just a part of the spectrum that involves impulsivity and compulsivity, right? Now, if you look at that, if the patient has impulsivity, They can definitely have drug addiction, gambling, obesity through binge eating. This definitely can be a problem. But look at all the other areas that causes problem because of higher degree of impulsivity. Pyromania, folks who set things on fire just to get pleasure out of it. Kleptomania, stealing things. Even if they don't need anything, they still continue to steal things, right? Not for their monetary value, but they steal things because the act of stealing itself is gratifying. Intermittent explosive disorder, for example, is highly impulsivity. It's a part of mania, ADHD, impulsive violence, including some personality issues like antisocial behavior and borderline behavior. And then we have some compulsivity involving orbitofrontal cortex, dorsal striatum, thalamus. You can see that the circuitry is pretty much the same, except for the difference here is the ventromedial prefrontal cortex in impulsivity compared to orbitofrontal cortex in compulsivity. And if you may have seen it, doesn't matter what spectrum or what specialty you are practicing in, you will see a whole lot of other compulsivity problem, like autism. Autistic kids do a lot of behavior compulsively. Patients with, for example, body dysmorphic disorder, they spend 2 hours or more just preoccupied with supposedly a body defect. Skin picking, OCD, somatization, worried about something wrong with their, the symptom they're having is something very, very wrong. For example, if they have a headache, they're worried about whether this is because of tumor. Compulsive shopping, for example, gambling, internet addiction, paraphilias, including hypersexuality, sex addiction. So this circuit is not only for drug addiction, but this circuit is also involved in a lot of different things. So drug addiction is not unique. It's just one part of the problem where these two circuits are going haywire. Right? If you visualize that in the form of the neuroanatomy and the neurocircuitry, it probably makes a lot of sense to see why these patients are struggling. And this is again a more neurotransmitter thing, same schematic diagram about the role of the endocannabinoids, the prefrontal cortex and the ventral tegmental area. Since I've talked already about it, I'll skip this slide without giving much details, but it involves the same mechanism just for a different scale. Now, moving on to the second topic, which probably applicable to all of my colleagues over here in the audience, is the substance diversion. Now, it doesn't matter what kind of substance it is, but substance diversion is a big issue, and I'll include some cases in this presentation. So what is substance diversion? It is unlawful channeling of regulated pharmaceuticals from legal sources to the illicit marketplace. And if you think that that these are just teenagers who are getting hold of their medication or their or getting into the medication cabinet at home and passing it on to their friends in school just to get high, think again, because this is a extensive market, an extensive problem, right? So it includes transferring drugs to people they were not prescribed for, obviously. Yeah, it is the illegal distribution or even abuse, consumption for the purpose not intended by the prescriber, usually for recreation, addiction, even financial gain, right? Then this may include deflection of the prescription drugs from the medical sources into the illegal market. And this happens, I just want to bring to your attention, this happens in a very extensive, hundreds of billions of dollars are involved in it. So does it happen only in selected few places in the chain, coming from the medication prescriber, collection to the collection from the pharmacy and the consumption by an individual? No, it can happen occur at any time, right? And so it can happen from the distributed from the manufacturer, anywhere in the chain, from the manufacturer to the chain store distribution center. It can happen in the general wholesale distributors to pharmacies, even in clinical settings, and obviously along with to the patients also. Unfortunately, members of the medical professions have also been known to be involved in diversion of prescription drugs for recreational purpose, relief of addiction, even monetary gain, self-medication for pain or sleep, or to address withdrawal symptoms. I've had a couple of my colleagues as patients who have gone through this unfortunate process and victim, or I would say the victim, because they struggle, right, with this kind of phenomena. So it's a very, very ugly side. I'm not saying it's very common in the medical professional, but when it happens, it's usually quite severe. Right. So drug diversion obviously leads to drug addiction, and the most importantly, it can lead to overdoses, emergency visits, and even death. Right. This data is a little bit older, 10 years old, but this is the most recent I could find. So the age-adjusted drug poisoning death rate among children has more than doubled from 6,200,000 in 2000 to 13.1. And if the same trajectory has happened in the last 10 years, this has probably gotten worse, right? And there has been about non-medical use of pharmaceuticals accounted for a 400% increase in substance abuse admissions through 2008. These are the most recent data I could find. All right. So it is a very, very significant increase, 400% increase in substance use admissions, right? And that includes threefold increase in treatment for opiate pain relievers, threefold increase. So this is a very real problem in terms of diversion. Anytime the patient is using substances that is not intended to be prescribed for, that is substance diversion. As a child psychiatrist, I can tell you a story about a patient, and they become more sophisticated. I typically treat ADHD folks through stimulants. I had to recently discharge a patient from a clinic. He was collecting prescription from me, and because there's a national shortage of stimulants, he would say that I couldn't find the medication, and he had to go to an outside the town pharmacy and would ask the prescription to be forwarded to that pharmacy. And because there's a lag time in the update of the government website, right? So it usually takes time for the government website to update the whole record so we can check. So this patient was getting two prescriptions filled up, same doses from two different pharmacies. So they're becoming more sophisticated, and they're realizing how substance can be used for diversion. It can be anything, right? So the most common manifestation, obviously, is overdose death. A study published from Cornell data looked specifically at oxycodone detected in postmortem analysis. It found only 39% of the one prescribed to be deceased. 39%, that means more than 61%. I'm sorry, for 61% had a illegitimate prescription of oxycodone. So whenever these substances are diverted, the risk of overdose death increases exponentially. That is the focus of my talk over here, right? And so quantifying the extent of problem obviously is very difficult. I was looking into some of the literature. Apparently, some other first world countries are much more far advanced in recognizing this problem than the US is, because most of the literature is either from Europe or Australia and New Zealand. So quantifying the extent of the problem is difficult. For opiates, diversion is proportional to the number of prescriptions issued without supervised dosing, and inversely proportional to the availability of heroin. Now, this is very, very interesting for me. It was very interesting to know this. So, heroin, being an illegal substance, is Schedule I substance. Its shipment, right, or its availability in the market is directly influences how the prescription opiates are being used. So if there's a whole lot of heroin available on the streets, there are less opiate diversion happens. But if it's not available, a whole lot of diversion and number of prescriptions without any supervision can get sipped into the market for illegal use, right? And pharmacological properties, of course, influence the drug, which drug will be used, right? Drugs, obviously, with rapid onset effect and those that produce greater effects from a single tablet are more desirable. For example, a single dose of 2 milligrams of alprazolam will produce similar effects to four tablets of family, almost 20 milligrams of diazepam. So I'm not talking about potency-wise. I'm talking about the euphoric effect, the calming effect, and the way how much lipid solubility the medication has. Weight by weight, in terms of receptor occupancy, alprazolam may be not as much powerful, but the chain reaction that it does after it hits the receptor, right, in terms of lipid solubility and how fast it goes into the central nervous system, this actually creates a problem. So alprazolam, particularly in our patient population, it's almost extremely dangerous to prescribe alprazolam, Xanax in our population. And so we are very careful, particularly when in our population, because they have major psychiatric issues, alprazolam remains a major concern for us. Right? Points of diversion, where the diversion can occur at any point of supply chain, right? Primary healthcare is the main target of prescription drug diversion, right? But it can happen in any hospital, a drug provided on hospital discharge can also be diverted. Prison inmates self-reported use in the year before incarceration found that 21% obtained prescription directly from a doctor in their name. So 1/5 of prescriptions are actually gotten by legitimate prescriptions. 43% were given to them by a friend or family member. And the other sources were like drug dealers purchasing from friends or family. But surprisingly, only few inmates reported forging or stealing scripts. This was very eye-opening for me when I was preparing this presentation, that most of it is directly from the physician or by a friend or family member, and very, very few whereby an electronic prescribing has made it more difficult to forge a prescription, obviously, or stealing scripts, which has almost become non-existent in the era of electronic medical record. Right? And also forced entry into pharmacies, warehouses, laboratories. When OxyContin first came in, we had seen a number of pharmacists putting up notices, we do not carry OxyContin. I mean, they would put banners outside just for the fear that people would break into the pharmacy. And they also been salvaged from clinical waste, like sharps and bins, diverted by healthcare workers within hospitals, right? Patients in aged care facilities, right? And it's very difficult to quantify how big, how extensive this problem is, right? And so one of the things that I look into that, when you look into the role of these substances involved in, say, for example, being intoxicated and driving. So in 2009, and this is the most recent I found, is about 4,000 tested of the, this is the NHTSA, which is the National Highway Traffic Safety Administration, of all the crashes, 4,000, which accounts for 18% of all fatal injury drivers. So 1 in 5, approximately 1 in 5 fatality that happens on the road is probably because of substances. And the GAO, which is the Government Accountability Office, recently, this was in 2009, they pulled up 5 states for frauding Medicaid involving controlled substances. So what they found was, and this is what was going on for the longest period of time, tens of thousands of Medicaid beneficiaries and providers were involved in potentially fraudulent and abusive purchases of controlled substances. And all these substances were ending up in the black market. And just 5 states resulted in about $63 million of Medicaid payments in fraudulent payments. Right? And many of them, more than 1,800 of them, were named on patients who were actually dead. And that resulted in 65 providers from being barred or excluded from the federal healthcare programs. So the numbers is very small. The clinicians or healthcare workers, whoever you want to call it, the numbers are very small, double digit, maybe triple digit by now. But the amount of damage that happens in terms of financial death and other things is pretty substantial. There was one case of point of diversion involved a physician who was charged in August 2010 for prescribing oxycodone to patients, and then who then sold this drug to the third drug parties. And so those third parties distributed more than 11,000, get this, 11,000 pills. And so they were getting prescription filled up to the Medicaid. Medicaid was paying for it, costing Medicaid $1 million, involving 11,000 oxycodone pills, all ending up on the streets. And the concerned physician was imprisoned for 36 months after pleading guilty. This was in December 2012. So these rare incidences are there, but brings to attention that this can be a major problem. So in this case, the U.S. attorney was involved, and he stated that, like heroin, oxycodone is a powerful, highly addictive, potentially lethal drug. In the proper hands, it can be obviously very important role in pain. But this doctor, the one who got 36 years was using this an opportunity to profit from drugs' popularity with recreational users. And he or she was writing bogus prescriptions that were being filled by Medicaid dollars, and obviously violating number of other healthcare laws and other things. The points of diversion, as I said, drug abuse warning network, they reported 35% of drug-related emergency department visits involved non-medical use of pharmaceuticals, right? 35%. One study in the USA found that the primary source of prescription drugs on the street included mostly older people and patients with chronic pain. And drugs were obtained via the internet from overseas vendors. Obviously, is becoming more frequent. And this was more seen in Australia, for example. This data is coming from Australia, as I was mentioning. The US data, I couldn't find much in the published world, but I'm sure the problem is very, very comparable. So if you look at the substances that are, if you look at the changes over time, comparison by year initiation of non-medical use of select prescription. If you look at the pain prescriptions that have actually in the 2014, the data I could get, actually gone down. Stimulants actually have gone up. So this is a little bit positive news for us, at least in this time period. Pain relievers dropped almost 30%, tranquilizers dropped almost 9%, stimulants, however, increased more than 10%, and so sedatives were there. And as you can see, the medications that are for high diversions are not just the opiates and stimulants, but you can look into that. There are some anabolic steroids also, including testosterone and other things. So it is not just Schedule II substances. It is a whole lot of other substances involved in this too. Some of the common things that we look into that, selling prescription drugs, for example, straight away, doctor shopping. Just this guy, I was a victim of doctor shopping. The example I just gave. Illegal internet pharmacies always are there. Drug theft is there. Prescription pad pharmacy, this is becoming more and more because of the electronic health records, and illicit prescribing through very, very few healthcare providers giving out those prescriptions. And the most commonly diverted drugs, benzos, still the top. All benzos, all opiates, certain stimulants, including antipsychotics. Now, we do have a clinic in the detention center, the County Detention Center. And I find that, and I'm learning from the administration there, the staff there, even substances that we don't regard as control or addicting, for example, quetiapine or Seroquel, is an abusable thing. Wellbutrin could be an abusable thing. Wellbutrin is actually crushed and snorted in the prison population to get high. So those can be, and it's used as a currency to get favors in detention center and prison population. So this can be, and obviously anesthetic drugs like ketamine and propofol, and GABA agonist can be problematic. But what was surprising for me that even olanzapine can be a commonly diverted drug. So what kind of precautions can we do? The most important is excessive caution patient. We suspect all patients, right? I mean, it's very difficult to find out. The patient in point, which I give an example, is a steadily employed blue collar worker without having any extensive history of substance abuse, was doing such practices. So documenting thoroughly when prescribing narcotics or choosing not to prescribe, right? Pads for those who are still using prescription pads. Keeping your DEA number and the license number confidential unless required by state law, right? Writing prescription pads, of course, those who are using prescription pads now very, very legitimately. Of course, moving to electronic record is very helpful. And adhering to strict refill policies. And obviously, in the next slide, I will say that the prescription drug monitoring program has been a lifesaver, but there are a number of pitfalls about relying too much on the prescription drug monitoring program because it is not always very fast. There's a lag time behind it. And it doesn't cover other substances. For example, it doesn't cover Seroquel or olanzapine. Right. In the interest of time, I will, these slides are available. If you guys need this electronic education link is also available. If you guys want this resources, I'll be happy to pass on to this.
Dr. Jain?
Yes.
So for the PMP opioid review that we have in our Texas Tech Cerner, does that tell me about medications prescribed out of the state as well, the controlled substances, or not?
I think it does. I usually don't rely on the Cerner one. I usually go on the website because the website entails covering almost all states. And the Cerner, I'm not really sure whether it covers just for Texas or it covers from other states also.
Okay.
But if you go to the PMP website, which uses you have to just register it one time, and that actually covers, and you can actually put the state where the patient is or suspected to be in. It screens almost all throughout the states. I think that would be my recommendation to try to go on the website, PMP website.
Thank you.
Okay. Moving on, training. Of course, training is important. Training doctors are identifying and treating addiction. I do want to move on to some of the safety practices. For example, what are the prescribing principles that can curb diversions of drugs which have got high potential abuse? This may sound rudimentary, but you'll be amazed how many times when we deviate from that, it results in problem. For example, completing a full evaluation assessment to verify the need for pain medication. It goes without saying that, but it does get sometimes in a very busy medical practice, sometimes it does get overlooked. Requesting a report of patient's medication history from the state prescription drug monitoring program, screening substance abuse and asking for medications when a patient is taking and why, right? And prescribing opiates only if alternate therapies do not deliver adequate pain relief, using pain assessment tools to monitor effectively, seeking a consult from a pain or other specialist, always involving other folks, other specialists, particularly when they're using 120 milligram equivalent of morphine, right? Or any of the opiate or Schedule II substances. And if the substance, if you suspect the diversion has occurred, the activity should be documented. The agency should be notified, because this will come directly to you. They can trace where the prescription is coming from, which prescription, which pharmacy, and who was the prescriber. It is all traceable. And so the law enforcement and local fraud alert networks are there. For the DEA, there is a website. This is the website where you can report theft or loss of controlled substances, right? And there are other websites, again, national hotlines are available from the Office of the Inspector General that controls the diversion of substances. More importantly, what are the signs of that the patient may be diverting things? Right. Again, it's kind of difficult to do that. Again, your intuition and your high suspiciousness of each and individual patient, and as a routine, asking questions routinely is probably your best protection. Accept what they tell value. It is also important to maintain a healthy degree of skepticism, right? Diverters come in many forms, so appearance may be very deceptive. So, don't go by the looks. If they're taking controlled substances, they can be diverting it. It is unpleasant as it is to consider people who work for you, other physicians, friends, even family members may be diverting. And this is the information I got from the website. So first thing, be wary of new patients with stories that don't seem to be quite right. Right? Diverters are more likely to claim that they're traveling through the town or on business or visiting relatives. So they're not local. Occasionally, they pose as government officials or pharmaceutical companies representatives. Now, this may be very important. They may be excessively complimentary about office facilities or your appearance or medical reputation in the community. So flattery has got a price. Deliberately request appointments towards the end of the day and may show up just after regular office hours. That's a big red flag. And particularly when patients are asking to be seen immediately. Refusal to give access to past medical records. And if pressed, they say they cannot remember who the previous provider was and which hospital they were. So they're very sketchy in giving what information about it, right? And many of these cases, this patient leave the office suddenly if things are not going their way. So some of these things, particularly in the context, when each one of the points is not very important, but when you put everything together along with high degree of suspicion, your gut instincts and your clinical experience should ring a bell for you, right? And patients may be knowing excessively about medication. I want X amount, X drug with X amount of milligrams and X times daily. That usually is suspicious, particularly when they're extremely well informed about specific medications. That is also a big red flag. Yeah, while it's true for many sick people to know their medications very well, right? It is also true for diverters. Yeah, they appear to have familiarity with the disease, and that seems to come straight from the textbook. And in some of the popular websites, they may actually say this is a big problem for us, particularly when we have so much educated individuals coming for, say, ADHD. Adult ADHD is very difficult for us to tease out. Dr. Google has been a good for most of us, but it also poses this problem. Many of these adults may recite the symptoms straight from the textbook, right? And so some of but there's inconsistency in the presentation. That is a big red flag. Strange symptoms, they may fake symptoms, such as they come up with typical symptoms like back pain, kidney stone, migraine headaches, toothaches. They may even attempt to alter the urine samples, right? So it comes in all strange samples. I want to skip this because I'm just running out of time for 4 more minutes. I want to bring to these 2 scales. One is the TAPS tool, which is a tobacco alcohol prescription medication tool. I have included that. These are both. And the other one is the Craft one. Now these are not foolproof. Of course, patients can misrepresent, say, but this is the standard of care. So prescribing controlled substance without having those questionnaires done, screening, This is the only way we can show that we had screened a patient of substances, and if the patient deliberately lies, that kind of gives you a little bit of protection in terms of providing controlled substance who happened to misuse a substance when he or she already had a history of substance abuse. This may not be a big issue for primary care, but in psychiatry, this is a big issue because a lot of these patients have previous history of substance abuse, and if we don't screen them adequately, it becomes a liability for us for giving them controlled substance. Right, so these two scales, the Kraft one and the TAPS tool, are very commonly used. They take less than 3 or 4 minutes to accomplish, and given once at least at the initial of the evaluation, first evaluation, can go a long way in actually alerting you of about possible misuse or diversion of substances. And that is all. Sorry, I went a little bit over time. I want to leave some time for questions, answers, or clarifications, if any.